Hi, everyone. My name is Mark Stebbin, and I'm very happy to welcome you to this IUSCI Canada webinar series. So today we have a presentation about the Canadian guidelines on HIV pre and post-exposure prophylaxis 2025 update. So, updated guideline on pre and post-exposure prophylaxis medication were published in the Canadian Medical Association Journal in December 2025. These guidelines offers Canadian healthcare providers, community members, and policymakers the latest insights on prescribing HIV prevention medication in an effort to ensure the life-saving drugs are equitably prescribed and bring down rising infection rates. The guidelines come at a critical time as research shows that HIV cases are spiking in Canada. The federal government reported 2,434 people newly diagnosed with HIV in Canada in 2023, which is a 35% increase over previous years. Marginalized communities face disproportionately higher cases, calling for more guidance and equitable prevention tools. And to do that, we're very happy to have Daryl Tan. He's an infectious disease physician and clinician scientist at St. Michael's Hospital, where he leads the Options Collaboratory in HIV STI treatment and prevention science. He is also an associate professor in the Department of Medicine and Institute of Health Policy, Management, and Evaluation at the University of Toronto, with a cross appointment in the Institute of Medical Science. His research focuses on clinical trials and implementation science in the areas of HIV prevention, HIV treatment, and sexually transmitted infections. Dr. Tan holds a Tier 2 Canada Research Chair in Biomedical HIV STI Prevention, is co-lead of the Prevention and Testing Think Tank of the CHR Pan-Canadian Network for HIV and STBBI Clinical Trial Research, CTN+, and is a member of the Governing Council of the International AIDS Society, and also was a lead author for these guidelines. So it's my honor to leave the microphone to Professor Tan for his presentation. Take it, Daryl.
Thank you so much, Mark, for that really kind introduction. And really, the honor is all mine. So I'm really privileged to have been asked to come join you all today and talk a little bit about this work that we did. So I'm going to go share my screen now, and I'll just ask you to let me know if it's in the right setting or if I need to switch the settings.
It's good.
It's good? Okay. Thanks so much. So yes, I'm thrilled to share with you a little bit about these guidelines that we put together and published on World AIDS Day a few months ago. It was a number of years in the making, actually. But before we do that, I'll just briefly recognize where I'm physically situated today, which is in Takaransa, the traditional territory of many Indigenous people today and for many centuries, of course. Notably the Mississaugas of the Credit, the Anishinaabe people, the Haudenosaunee people, the Chippewa, the Huron-Wendat people. It's wonderful to see so many names of folks calling in from across Turtle Island. And normally in a webinar like this, I kind of invite people, if they'd like to share in the chat, briefly acknowledge the territory that you're calling in from. I know there's a lot of us here, but I do think it's nice to just really recognize the traditional territory that we're all on. And we're here to talk about something that really is relevant to Indigenous people in this country, other equity deserving groups as well, of course, but we all know that tragically in some Indigenous communities across this country, we have a grossly disproportionate rate of new infections that's occurring and a large number of prevalent infections. Many of them are undiagnosed. It's an ongoing health crisis. And I think it's really just important that we situate the work that we're going to talk about today and that all the work that there is for us all to do together ahead in light of recognition of where we are and how we got to be in this geographical and temporal space. So that's where I am. And the work we hope will apply across Turtle Island. I'll also just disclose that my institution has received support from a number of pharmaceutical company partners for participation in industry-sponsored clinical research, mostly on the HIV treatment side as opposed to the prevention side, but also some investigator-initiated research on the prevention side in Gilead. I'll also note that this presentation absolutely will include some discussion of off-label use of medications, notably, this is not the only one, but notably all PEP is off-label in Canada as it is pretty much around the world. So the objectives for today were to really talk about the guidelines that we put out on December 1st. This is just a screenshot of the synopsis of the article that you'll see. Another objective of today's talk was to just talk a little bit about guideline development and just think about best practices. I'm kind of going to do that obliquely by just explaining how we went about doing things, and happy to engage in some discussion about either these topics, the content of the guideline or the methods for their development in the Q&A session at the end. But before we get into the methods, I did just want to really recognize the amazing team of people that are all listed here as co-authors. My co-chair is listed second, Mark Hall, who co-chaired the initial development of the guidelines with me way back when we initiated this a few years ago in 2017 and published in 2018. Stanley, the third author, helped to coordinate a lot of the work, and then all the other individuals you see listed here were panelists who contributed their expertise, and I think you'll recognize probably some of the individuals that are listed there. They really were brought together because of their diverse disciplinary expertise, covering not only infectious disease, but also primary care, internal medicine, emergency medicine, adolescent medicine, as well as public health, as well as community members, as well as people with backgrounds in nursing, pharmacy, implementation, so a diverse range of disciplinary expertise, also with a range of lived experiences, as well as professional experiences serving communities that are disproportionately affected by the epidemic in Canada, not only with respect to sex and gender identity and sexual orientation, but also ethno-racial background and indigeneity as well. And we tried to obtain some degree of geographic diversity as well. I will not pretend that we were perfect in reaching the full range of diversity that one might consider optimal, but we really did try hard, and I do think that ultimately we're proud of the product that we were able to get. So, with respect to the methods that we used a system called GRADE, which is fast becoming the norm or the standard in terms of guideline development around the world. It's a rigorous methodology that keeps on getting more and more sophisticated, elaborate, and it at its core comes down to just a few simple steps. First, one wants to formulate some clinical questions that you hope that the guideline would address. In our case, it was who to prescribe PEP and PrEP to, and what should be prescribed. To some extent, how to actually do that was other material, although it wasn't some of our core questions that we addressed in the recommendations. A second step is to conduct systematic reviews of literature, including rating the quality or the certainty of the evidence that's out there. And then what one typically thinks of as a guideline process is that the panel has to deliberate on that evidence. But what's particular about GRADE, and I think elevates this methodology compared to how many guidelines used to be put together some years ago, and in some cases still are, is that it encourages the panel to use a very explicit evidence to decision-making framework and to make all of the decisions and considerations that came up in the discussions transparent to the end user. I think old guidelines tended to be quite subjective, and there wasn't always a lot of clarity on how panel members went from the evidence and drew a line to the final recommendation. Perhaps that's still the case in some cases, but GRADE really encourages guideline panels to make that more transparent. This is slightly out of order, but this is a list of panel members. I meant to put this prior, it's a prior slide, but just to reiterate the point that we have tremendous diversity within our panel with respect to where people work, what their expertise is, and a big shout out to all of these individuals. back to the methodology. So this is a table I know you probably cannot read in detail, but I'll just walk you through at a high level what it's trying to show. This is that evidence to decision-making framework I referred to just a moment ago. You can see on the left-hand column a list of 10 different domains that the panel had to think through for every given question that we were addressing and ultimately any recommendation that we were trying to make. So the first one is, to what extent is this issue a big public health problem? What are the desirable and undesirable effects of the intervention that you're considering recommending? What's the certainty of the evidence? What are the values that people might have among the people that you're trying to make a recommendation for? What's the balance between the desirable and undesirable effects? The seventh item here is resource use. Is this a good use of public resources or financial resources in general? What are some equity considerations around the recommendation you're thinking about? And then what's its acceptability and feasibility? You can see that this is not simply, is this a harmful drug or is this an efficacious drug? It's really much more than that. And for each one of those dimensions, our panel spent quite a bit of time actually thinking through, would our answer be, which of these answer options would it be? Once one does that, one looks at the totality of answers that one has made as a group and tries to say, are these overall pointing us towards the left, the right, or the middle of this continuum here at the bottom? And you can see that the grade formulation really asks the panel members, panels ultimately issue only one of four types of different recommendations. It can either be strong or weak. It can either be for or against the intervention that you're thinking about. Furthermore, you grade the certainty of the evidence, A, B, C, or D, as shown here. And then every recommendation will therefore end up being a 1 or a 2, and then an A, B, C, or D. So just to elaborate on that a little bit more, it's important to recognize that although grade uses this particular terminology, strong and weak, a weak, also known as a conditional recommendation, is not the same thing as saying it's a flimsy recommendation or we don't really believe in this recommendation or something. As you can see, it's still been arrived at through a very rigorous process, and the process itself is actually identical regardless of what the outcome is. But the meaning of a weak or conditional recommendation is shown on this slide. For different stakeholder groups or audiences, it'll have different implications. For patients, it would mean that this is a recommendation that most people would want, but not everyone. For clinicians, it's important that the clinician would recognize that this is going to be differently applicable to different patients. And for policymakers, they need to recognize that it's not a cut and dry thing. This is something that should just be applied across the board, that there's going to need to be some substantial debate with stakeholders about whether this really should be a formal policy for every single person in that jurisdiction. In contrast, at the top of the slide, you see that a strong recommendation is not universal, but much more generalizable, that it's true that most people are really going to want this thing and that it's appropriate for most people. Now, there are also some parts of the guideline, in any grade guideline, that will just give, advice on how to do things. And that's not content that gets graded with a 1 or a 2 and an A, B, C, or D. It's just advice that we're giving out based on other review of literature and other expertise that the panel had. And there's another category of statements that kind of have the appearance of recommendations, but they're differently labeled. They're labeled as good practice statements. And just to outline what that means, it's still something the panel is saying that they think people should do, but it's not formally graded. And the reason for that is it's just argued that these are things that are so commonsensical, so clear, so intuitive that it's not a good use of resources and time to do a systematic review, to look at that, to deliberate on all those dimensions, and then come up with a graded recommendation on it. It's just clear that this is something that we should do, and we agree on that. And so those are labeled as good practice statements. We have several of those in our guideline. Now, another thing that's, I think, good practice, but not formally part of grade to do is to do community consultations. Now, community input and patient perspectives are absolutely recommended as part of the grade process. But one thing that we really wanted to do is to push that just a little bit further and do some formal consultations with key populations that are impacted by the epidemic in this country. So In the year before we actually started to deliberate on the data, we met with each of the organizations listed here. They're all either national or regional in scope. And aside from the bottom two, which relate to two different professions, nurses and pharmacists, they all are organizations that seek to represent the perspectives of the lived experiences of key populations across the country. I'm not going to read them all out. You can see them listed here. What we did in those meetings was we had about 4 panel members, usually a chair, and then a diversity of 3 other panel members, meet with representatives of the organizations on Zoom to talk about their hopes and their recommendations for the guideline update, to contemplate what would be the key health outcomes we should be thinking about. And what emerged from those discussions are summarized at the bottom here. So it was very clear that across the board, people really wanted this guideline to speak to the importance of broadening eligibility and access to PEP and PrEP. They emphasized the importance of inclusive messaging and language that we tried to enact. And then finally, they emphasized the importance of engaging a wider range of providers in the rollout of PEP and PrEP. I think that's another dimension of this broadening access piece. We really had that frame of mind when we went about deliberating on the data. One other thing I'll just state methodologically, that many guideline panels are, still working towards, I'll say, and certainly our public, our journal that of choice, so the Canadian Medical Association journal, was quite clear that they wanted to emphasize was adherence with this set of guidelines on disclosures of conflicts of interest. Common that folks may have some degree of connections to, partnerships with pharmaceutical partners and other for-profit entities and other entities that just have clear stated interests. But the current guidelines go beyond the simple declaration of those conflicts of interest, but really recommend different measures be taken to try to minimize the impact of those on deliberations. And one thing that we actually found ourselves needing to do in order to properly adhere with this process was, for some of the decisions that we had already started to make, we actually had to go back and reconvene our panel, including only individuals who had no conflicts of interest at all with the given manufacturers of the given drug, for example, in order to make sure that we adhered with these standards. So it is a higher bar than I think has sometimes been the case for guideline development in the past. Ultimately, what we end up with is this. We end up with a synopsis article, which is the screenshot that I showed you a few minutes ago. That's the CMHA article, and it summarizes the methods, the grade recommendations, and the key justifications for that, and it has some key tables that would make reference to the information a bit quicker for the end user. That article is actually not the full guideline. The full guideline is actually Appendix 1 of the article. It's available online. It is just another click away, and it has a lot of additional sections, a lot of background information about the epidemiology of HIV in Canada, the biology of HIV transmission, the details of HIV testing. It talks in more detail about PEP and PrEP in specific populations, in addition to the overall recommendations. So a few examples are listed here. According to grade, it's always important to include a section that compares the guideline with other guidelines that are out there, and to also comment on research priorities. And then finally, there are some other appendices that are included beyond Appendix 1, which is the full guideline. I'll speak to this in just a minute. There's an appendix all about HIV risk assessment tools, another that provides the evidence summaries that we were working off of, as well as, for full transparency, very lengthy list of all the different evidence to decision-making tables that we used, along with a narrative description of how we arrived at the panel at the individual decisions that we. And before getting to the content, I'll just finally give a shout out to these 4 wonderful organizations. CHAP, which is the CHAP and CANAC, which are the Canadian professional organizations for pharmacists and nurses involved in HIV care, respectively. In Canada, CAPE, which is the Canadian Association of Emergency Physicians, and then the Canadian Public Health Association. We're really grateful to all of these organizations for their endorsement guideline formally. All right. So with that background about how we went about doing all of this, I'll move in the next 10 minutes or so to talk a little bit about post-exposure prophylaxis, the indications for this and some regimens, recommendations, as well as after that, we'll talk about PrEP, pre-exposure prophylaxis, and then we'll wrap up with some closing comments. before taking everyone's questions and discussion points. So, of course, the decisions around PEP, post-exposure prophylaxis, have to take a lot of background into consideration about the risk of HIV transmission that's associated with any individual type of exposure. So the guideline, as I mentioned, contains a whole section discussing the biology of HIV transmission and notably just how not easily transmitted it is. Importantly, we wanted to really highlight that we formally, of course, not up for debate, it's just of course, but we actively promote, that the concept of undetectable equals untransmittable as a message. And an important caveat is that for transmission purposes, undetectable, when we talk about U equals U, can be defined as a viral load less than 200 copies per milliliter of HIV RNA, even though, as you all know, of course, clinical viral load assays that are in use in Canada typically use much lower thresholds, for example, less than 20. And we also point out that the initial iteration of our guidelines a few years ago kind of quibbles about the lack of certainty regarding whether U equals U applied in the setting of someone having another co-incident STI. And we went back to that issue in this iteration and really felt that there wasn't evidence that the presence of an STI changes that fact. And so we state that. One final really important caveat, and you'll see this becomes very relevant to our final recommendations in a moment, is to recognize that it's not clear whether the U equals U principle, which clearly applies and is well established for sexual transmission, applies to needle-based exposures. So you'll see that come up in just a couple of minutes. Now, another important point before we move on to the recommendations is that clinicians need to consider local epidemiology in considering whether a person to whom a patient was exposed might have transmissible HIV or not. So we'll come back to that in just a minute as well. Those are just high-level points about the risk of HIV transmission. And in the recommendations, we talk about how a PEP decision really needs to consider a matrix of two key considerations. One is, what actually happened? And you can see a table here that we largely adapt from another source that gives you the estimated per act risk of an HIV transmission event occurring when someone has a different type of exposure to someone who has transmissible HIV. Now, we've categorized them according to the words that you see on the left-hand side of this table. And I want to just draw attention to one small grammatical issue that actually I think has potential profound societal implications. We made a very conscious decision. We had some lovely input from colleagues from the Canadian HIV/AIDS legal network about the choice of using this word in the upper left-hand corner, higher risk. You'll note that the word is not high risk, and that's a distinction that I want to make. The reason we chose to use the word higher rather than high risk is that for these activities, receptive anal sex, needle sharing, although these risks are higher than the other activities listed here, the actual per act risk of exposure is still very low in absolute terms. And our prior labeling as a collective we of these types of activities as being high risk has actually been misused in legal contexts inappropriately, in my opinion, to argue that these were high risk events. And this has contributed unintentionally, but it has contributed in the past to criminalization of HIV, which we all know Canada is a shameful leader in globally. Like leader in the bad sense, right? There's too much criminalization. There is criminalization, which should not be at all thing at all, in my opinion. So I just encourage people to think about how they use these words. We encourage you to use the word higher, not high, when referring to these activities. Okay, so a PEP decision has to consider what happened, and it also has to consider, as we mentioned a moment ago, the local epidemiology. With whom, what's the likelihood that the person was actually in contact with HIV? So here's a reproduction of some table from PHAC. It's a little outdated now, 2023. The 2024 numbers are also out. And you can see, according to exposure category, the number and proportion of first-time HIV cases by sex and exposure category in this country. And so, of course, we all know that historically, gay, bisexual, other men, and sex with men have been grossly overrepresented in the epidemic, but you can see that these numbers are starting to shift. We're actually seeing a really considerable and alarming proportion of infections that are occurring in people who are assigned female sex at birth, in the context of injection drug use. And I won't walk through the whole table, but one really needs to know these global numbers at the national level, but also much more locally. So this is a provincial and territorial map, which is still not nuanced enough, but it does emphasize some really important geographic disparities that we're all aware of, that really alarming rise in cases that we're seeing in the prairie provinces, Saskatchewan and Manitoba, but in many provinces and territories, these rates are going up in 2023 compared to 22. Started to temper down again the year after, but know your local epi is the bottom line, and consider this factor when you're making a PEP decision. Finally, we have a caveat in the guidelines saying it is really important that even though we need to use this information to make an individual clinical decision around PEP, we have to recognize that this can contribute to stigma and discrimination, which is not the goal, and we need to be very thoughtful in how we use language to talk about HIV risk in such a way that it serves the patients in front of us, the person in front of us, but does not inadvertently stigmatize entire populations, which is a very delicate thing to do. Ultimately, here's where the money slide is. This is what we ultimately recommended be done when we look at that matrix of what happened and with whom. You can see at the bottom here, we're going to work through this table quickly from the bottom up. There's many situations in which it's quite clear to us as a panel, these are good practice statements. PEP is not needed. If the source person is HIV negative and that's known, or if their HIV status unknown and from the general population, then across the board we say it's just not needed to initiate PEP. Also not needed to initiate PEP if it's in the setting of receiving oral sex. Performing oral sex is also very low risk in absolute terms and in relative terms. You'll see that there's one box here where we say, okay, fine, there have been some rare case reports, some unusual circumstances where people have been thought to acquire HIV related to performing oral sex, even though in general we really think of this as a very, very, very low risk activity. So we say, okay, fine, case by case decision. If there is a known exposure to someone who has detectable viremia or might be from a population where we know there's a high prevalence of HIV. The two cut and dry situations where we say, yes, initiate PEP would be in those sorts of exposures that are percutaneous or anal or vaginal sex with someone who is described as such. And then in these other situations, you see they're all case-by-case decisions. So these are kind of exposures through compromised skin or mucosa, or in that circumstance that we talked about a moment ago, where it's not clear whether the U equals U data absolutely always going to apply. It's not certain that we don't have evidence that absolutely applies in a percutaneous exposure case. What we typically say here, talk about it with the person, give them the analogy, and think it through with them, talk it through it, and use this shared decision-making. Hope that is helpful. I'm going to move in just a couple minutes to talk about the PEP regimens before we finish up with PrEP. And like I said, to inform all of our decisions, we conducted systematic reviews, which I won't go over the results of in detail, but for the PEP literature, we thought about these four outcomes: HIV acquisition risk, which we know is very low across the board, but also more importantly, adherence with PEP, toxicity and tolerability of PEP. And then we also, when we were working through that evidence to decision-making framework, thought about these other dimensions. And here are just a few examples. It's not an exhaustive list, how we considered some other dimensions. With respect to efficacy, we didn't just look at what the studies showed. We applied what we know about the genetic barrier to resistance of given drugs, because that could be a factor that influences the efficacy of PEP. We thought about the cost of the drugs. We used publicly available data from Ontario to do that. And then a few examples of how we thought about equity issues. We would sometimes downgrade a recommendation because of the lack of data in pregnant people, if there are food requirements that we thought could pose a barrier to people who have food insecurity in taking their PEP medications, et cetera. And then some feasibility considerations, acceptability considerations that you can see listed here. So when we applied all that, you can look at Appendix 4 and see all of the decisions that we made. This is what we landed on. I'll just talk through briefly and tell you that a strong recommendation 4 was restricted to 2 regimens. One of them was bictegravir with tenofovir, alafenamide, and emtricitabine. Of course, this is better known as Biktarvy. Those are the trade names. Also for dolutegravir, combined with tenofovir disoproxil fumarate with emtricitabine, also sometimes known as Tivicay with generic Truvada. Okay. All these others, I'm not going to read out, but you can see the key point being that there's actually a lot of regimens that are out there that are reasonable to consider, and they might be the preferred regimen in unique circumstances where you just don't have access to something, or there's a particular drug interaction or intolerance issue, or what have you. You can read much more about that in the full guideline. Here are some examples of some of the how-to recommendations or suggested practical advice on how to prescribe PEP to someone. The key points here are to incorporate other screening for STBBIs, hepatitis, bacterial STIs like gonorrhea, chlamydia, syphilis into your PEP workflow. We also tried to streamline the baseline hematology and chemistry investigations to minimize those because so often they're just really not going to change anything. That's all I'll say about that. I'm going to finish with just 2 PEP implementation issues, which are the issue of having starter kits available in settings where someone might first present for PEP, such as an emergency or urgent care clinic. The idea here is that we could facilitate PEP initiation by dispensing just a few days of medication to someone before they go on to have a more detailed assessment by an expert and make a decision about whether they continue their PEP for the full 28 days or not. On the right-hand side, you can see this other concept of PEP in pocket, sometimes also called PEP on demand or self-started PEP. The idea here is that one could consider giving a prescription for PEP to someone who's not had a recent exposure, but who forecasts that they might have very rarely a higher risk exposure. And for some reason, they just don't feel like PrEP is the right decision for them or option for them. Because of that variability in what people prefer, we thought this is something we should issue some recommendations on as well. And here are the recommendations that we issued. We just think that starter packs should be considered, that they should be available. There's actually evidence to say that they're associated with lower rates of PEP completion. So we don't recommend that they be used across the board, but the key point is to facilitate access by making them available. On the PEP in pocket side, we recognize that the data supporting this approach is actually of lower quality than the data supporting PrEP, which is very high quality data. But because it expands options for people, expands access to modalities that might appeal to different people, we suggest that it be considered for people who have very infrequent, moderate to high risk exposures. So with that, I'm going to move to PrEP and make sure we still have time for some discussion at the end. So once again, we thought as a panel for PrEP about what are the indications for PrEP and what are the regimens that should be used. I'll note that I've placed PrEP after PEP in this presentation slightly intentionally because PEP has existed for longer and PrEP is a newer kid on the block, even though these days we talk about PrEP much more. But I think it's important to recognize that for many people, PEP can be a really useful gateway to PrEP. And in fact, the continuum of care for many people should not end with their final HIV test 12 weeks after their exposure that led them to take PrEP, but it should actually really lead to a discussion about the pros and cons of using PrEP in that person, and that we actually have a good practice statement saying that people should be actively recommended to consider PrEP if they finish PEP because there's a known higher incidence of HIV in folks who have used PEP. Okay, but who else to prescribe PrEP to? This is one place where we're really pleased that we made quite a shift in how we thought about this issue compared to our earlier guidelines a few years ago. The current guideline emphasizes that the impetus to start on PrEP can come about in different ways. Sometimes it comes from the person themselves. Sometimes it comes from a healthcare provider. And we have 2 good practice statements that speak to these scenarios. The first one makes the point that it is reasonable to prescribe HIV PrEP to adolescents and adults who request it. And that's a real key change from how we had framed things in earlier guidelines where we were critiqued, I think quite rightfully so, for framing these decisions as though the clinicians are the final, gatekeepers of who should and shouldn't have access. We thought about things in terms of eligibility for PrEP. Are you, yes or no, eligible? And here we're saying no. People can come about and ask for it themselves. I'm going to elaborate on that right here and say, there's lots of reasons that we know people may not disclose detailed HIV risk information to their clinicians. And allowing for this sort of behavior where someone just asks for it and then we promote access to it will increase use overall. And it's very unlikely that, harm would accrue from this sort of approach. It's unlikely that people who have quote unquote no need for PrEP would ask for it and suffer harms from it. And we really want to avoid gatekeeping. So this is a real sea change, and we really encourage people to think about how they can put this into practice in their setting. But this doesn't mean that healthcare providers don't have a role. As we said, we have another good practice statement that says clinicians are encouraged to actively assess HIV risk during routine health visits. That word routine is important too. It's not just in a visit where you're talking about sex already, but think creatively about other sorts of routine visits where you can identify people who are at increased risk, who would benefit from PrEP, but who have not requested it themselves, and then recommend PrEP to them. The point is that a lot of people still don't know about this. This is not their fault. It's because we as a society have not done a good enough job of promoting it. We know that people also underestimate their risk, and we want clinicians to proactively integrate this into lots of different health visits. Again, you'll remember that our community consultations told us that people really wanted a diverse range of providers to make this more accessible. So to aid clinicians in that effort, we did another systematic review that we realized that we needed to undertake. It's published, as you can see here. It was a review of the different HIV risk assessment tools that exist out there. And all of these are summarized in Appendix 2 of the guideline. They're created into a standardized format, which might make it easier for people to pick and choose a tool that they think will work well for them. We don't formally recommend one over the other. This article talks about the relative pros and cons of these tools. Notably, we found that there are some populations that are disproportionately affected by HIV in Canada for whom there really are not good existing HIV risk assessment tools, notably cisgender women. All of the tools that exist for cisgender women are very contextually appropriate for the African continent, but really do not translate well to other settings, even in people who have migrated from Africa. So we've identified some gaps there, but the point is take a look at the tools, see what works for you, what's implementable within your EMR, etc. Based on those decisions around, who are we going to prescribe PrEP to, when we move to the next set of questions, which is which regimens should be prescribed. And the way this somewhat busy table is set up, I'll just orient you to, is that on the left-hand column, you see 4 rows applying to different populations. And the language there was chosen to try to be as inclusive as possible. We do have a big caveat around all of that, which is that for people whose assigned sex at birth and gender identity may not align, or whose partners, for whom that might be true for their partners, we encourage clinicians to just think carefully about which recommendation just logically feels like it would apply most appropriately, considering the person's specific anatomy and the partners that they do have. Okay, so we really encourage an inclusive approach, although of course we had to take a simplifying approach to creating this summary set of recommendations. In the columns, you'll see another major highlight of our 2025 guideline update, which is that we are now in a really exciting era of PrEP choice in Canada. Back when we published the first guideline, the only form of PrEP that really existed was oral TDF-FTC. It could be used in a 2-1-1 fashion or on-demand fashion at that time. But today, we also have another daily oral option, TAF-FTC. It's not for alafenamide with emtricitabine, also known as the trade name Descovy. And then a real leap forward is that we now have long-acting injectable PrEP in the form of cabotegravir, so injectable CAB-LA for long-acting. I'd like to highlight that Canada, I think, really is uniquely positioned globally to make this concept of PrEP choice come alive. And I really encourage all of us to think about how we can be part of that real innovation. Although these products are approved by regulatory bodies around the world in many cases, in many high-income settings that are more comparable to Canada, they are not publicly reimbursed. Notably, the injectable CAB-LA is not publicly reimbursed, whereas that is the case in some, not all, jurisdictions in this country. And that really means that we have true choice available to many, not enough, but many people in this country. And I think we need to be thinking about how we can harness that diversity of choice, maximize uptake. Okay, with that background here, I'm not going to walk through every single box here. You can kind of see how we have some strong recommendations for some interventions, some weak recommendations for some interventions. Again, that means that they are still sometimes very reasonable to use. There's only a couple situations where we have recommendations against an intervention, and that's for the use of on-demand or 2-1-1 oral TDF-FTC in cisgender women where the risk is related to heterosexual activity, or people where the main risk would be related to the use of injection drugs. And the reason for that is not simply that there are no data, but rather that the data that we do have, for instance, in cisgender women, has actually shown us that there's reason to be concerned that it might actually not work. That in the setting of parenteral exposure for people who inject drugs, there are reasons, to think that we can't be certain that this will work. So there are real reservations about that. There are other situations where clinical trials have not been done of a particular regimen in a particular population, but the panel did feel comfortable extrapolating from other high-quality evidence in other populations and considering all the other values that we have in that evidence to decision-making framework, it landed on a weak recommendation for that intervention. Notably, that's the case for many of our recommendations around the use of daily oral TDF. That's all I'll say about the recommendations on the regimens. Once again, we have a table of suggested baseline and follow-up evaluations for PrEP. They're listed here. Many of the same principles apply. Think carefully about STBBI screening on an ongoing basis. You'll also see that we have retained some suggestions from our earlier iteration of the guidelines where we encourage people to think about coexisting conditions and really think broadly about how sexual health is closely related to other endemics, such as mental health conditions that are relevant to the key populations that we're serving. There's lots of asterisks or little footnotes to this table that I don't have time to talk through, but you'll see those all noted through this table. So do take a look at that table and see whether those provides useful information to you when you're caring for your patients. There's one last topic that I'm going to cover in the content area before we wrap up with a couple closing comments and then take some discussion and questions. This is the last topic where we actually issued a formal recommendation on what to do. And it's the only recommendation that we have that isn't one of those, who to prescribe to or what to prescribe sorts of questions. We posed another clinical question about this risk of what has been nicknamed LEVI, or the Levi syndrome, long-acting early viral inhibition syndrome. This might feel a little bit arcane if you haven't heard this before, but it is important to recognize it's a thing that has arisen in the context of some of the early data that was seen with long-acting injectable cabotegravir as PrEP. The concern arose because the long pharmacokinetic tail of this drug means that there's low levels of cabotegravir in people lasting for a year plus, depending on sex assigned at birth and other considerations. And if someone is exposed to HIV and unfortunately contracts HIV from that exposure while the drug is still present in their body at sub-protective levels, there is not only the concern of seroconversion and resistance emerging, but also a delay in the ability to detect the infection, because the low levels of drug slow or blunt the antibody response that we're looking for in a standard serologic test. And that can contribute to the risk of resistance. So early data from those cabotegravir studies had suggested that because of this phenomenon, perhaps we needed to use different methods to screen for HIV in someone who is on this drug or has recently finished using this drug. And the US guidelines that came out shortly thereafter went so far as to routinely recommend that all people using any form of PrEP be screened for HIV using an HIV RNA test preferentially, which is quite a bold leap in terms of a recommendation. So we looked at this issue because we thought that would have major implications if that's how we recommended its rollout. We ultimately suggested not doing so. The rationale is detailed in the guideline appendix in much more depth, so you can take a look at that. To be very clear, we suggest not routinely using this test. In other words, we're not saying this is the test that should be used in all cases. We still have some caveats around that. It could be a reasonable thing to do. There are good reasons that you might find it valuable, but it's not a routine recommendation, and that has implications for feasibility, uptake, scale up, etc. We can talk more about that later if you'd like. So I've gone through a lot of material today, and it's not reasonable to expect anyone to just absorb it all, with one quick flip through or one quick webinar that you've attended. So in partnership with Katie, we're thrilled to have co-developed some online modules that are available in English, également disponible en français, that you can see the links for here. Maybe we can share those in the chat later on. There's a series of 4 online modules to help train providers of different sorts on the guideline content, who to prescribe to, what to prescribe for each of PEP and PrEP. They're accredited by these organizations listed here, so people can get their CME credits if they need those by completing them, and we really encourage you to take a look if you think they'd be helpful to you. An elephant in the room is that we all know, and we're all very excited about, the imminent arrival of lenacapavir as a long-acting 6-monthly PrEP option. We anticipate that might be approved in Canada very soon. So anticipating that would come soon, we are going to do an update to the guideline that will be posted most likely as an online supplement to the existing guidelines. So keep an eye out for that on our CTM Plus website. The last thing I'm just going to share as an add-on is actually not directly related to the guidelines at all, but just to let you know that another initiative that my team has been working on over the last while has been also aimed at trying to think about how to scale up uptake of PrEP. It's specifically applicable to gay, bisexual, other heterosexual men, and it's a project that's funded by the Ontario HIV Treatment Network, so it's relevant to those of you who might be practicing in primary care in Ontario and seeing these individuals in your practice. The goal here was, because we know from a lot of implementation data that oftentimes people who are recommended PrEP receive that recommendation and then say thanks but no thanks, they actually decline the offer. We wanted to create a module to support people in having that conversation with that client, patient, potential user, to encourage them to really think critically about whether maybe PrEP might be right for them. It was developed, we developed this module in collaboration with a number of different professionals from different disciplines and community partners. And I just wanted to do a quick shout out to a little trial that we are doing. It's a really, really simple trial where we ask people to, if they meet these criteria, you're a practicing healthcare worker in Ontario who thinks you might be seeing GBM in your practice who might be suitable for PrEP. If you consent to do this really short questionnaire, you'd be either given this module right away or given it at the end of the study. And we just are interested in your opinions on whether you find it helpful or not. There's the option of maybe even putting it in practice with some patients and telling us what that looks like. If you might at all be interested in this, I did put some contact information for our lab team members who are running the study here. optionslab@unityhealth.to is the email address for Charles, who would happily let you know more about the study. That's a bit of a side to the main focus of today's presentation, which is about the guidelines, but I do hope it's been useful to hear about some of this content. I want to thank the organizers, EUC and CPHA for putting this on. Thank you all for being here, and I'm really happy to take any questions or just hear comments that you might have about any of this content. Thanks so much.
Thank you, Daryl. Very interesting data that you've shared with us. Some questions are coming in. What is your take on the PrEP injection for a person using PWUD?
Yeah, great. Thanks. Thanks for that question, Heather, and thanks, Mark, for reading that. So, okay, I see here that in your written question you're asking about lenacapavir, and what I'll start by saying very briefly is just that all we have in the guidelines so far is recommendations around cabotegravir, so a 2-monthly. product. Now, this was one of those situations that, as I was alluding to, where the panel made a lot of deliberations about this and ultimately landed on a weak recommendation for, a conditional recommendation for. In other words, it's reasonable to prescribe it in this context, recognizing that there actually are not clinical trial data on its use in that setting. There's a little bit of observational experience that's emerging. But what we reasoned was that there's not particularly compelling reasons to think that it wouldn't work. There's a lot to be gained by the leap ahead that this offers in terms of adherence, challenges that many people face, privacy barriers that people face, stigma barriers, and that we thought that the net benefit of putting it forward a weak recommendation for its use outweighed any potential theoretical uncertainties around the lack of RCT level data. And I would basically extend the same arguments to lenacapavir. We haven't yet seen, there are data that are coming regarding the use of lenacapavir in people who inject drugs, but they're not in the public domain yet. And we haven't issued guidelines on that. So stay tuned for exactly how we articulate that guideline, but that's my long-winded answer to our thoughts on injectables we do have right now.
Thank you. What about the pricing? Do you see that there will be a problem with access, with pricing that may differ from jurisdiction, territory, provinces, or different status of people?
Absolutely. Such an important issue to bring up, Mark. So thanks for raising that. Absolutely, positively, price is a huge barrier. We know that from tons of research that's been done around the world, including in Canada. We have some natural experiments in Canada where some jurisdictions have made some forms of PrEP freely available universally and others have not. And we see differences in uptake and willingness and awareness that correlate with that. Cost is absolutely a reason that some of the PEP regimens that we recommended were not recommended as first-line options. And analogously, it's part of the reason that TAF FTC, Descovy, you might remember that in that table I showed you, none of the recommendations around Descovy or TAF FTC were strong recommendations. And one of the major reasons for it, we've got an excellent safety and efficacy profile, but cost is a major driver that will limit access. So 100% across the board that applies to the new technologies, the injectables, lenacapavir. We really, really hope it is priced appropriately, but we will have to see.
What about the interactions? Some of the population that are targeted for PEP and PrEP are taking drugs for mental health issues or metabolic disease. Is there a significant interaction we have to watch not to create problem to these people?
Yeah, it's a great point. And the happy news, right, is that for the most part, the drugs that we use for PrEP, and to some extent, to a large extent, I'll say, the drugs that we recommend as our first-line options for PEP really don't have a lot of clinically important drug-drug interactions. So it's a real advantage, certainly of the oral PrEP options, okay, the simplest of them. Yes, it's true that the third agents that we use for some of our PEP regimens, certainly injectables, there can be some interactions with some drugs, rifampin, carbamazepine, some of the anti-epileptic drugs, but the list is fairly short. There is some content in the guidelines that we encourage people to look at if they're ever unsure, and of course, consult with a pharmacist. But for the most part, the simple way to remember it is for the oral PrEP options, happily, there really are not drug-drug interactions as major barriers for the most part.
What would you answer someone that talks about the HIV vaccines, because they talk of PEP and PrEP as vaccines?
Yeah, it's such a great question. And this is a real, what to say about that? I mean, it's a real big issue around science literacy, I think. There's so many reasons that I'm sure we all agree that we need to do a better job at increasing science literacy in the general population. Yeah, these are not vaccines. People equate the fact that it's an injection perhaps with a vaccine. But of course, And there's a lot of baggage, of course, that we're unfortunately living with these days around people's interest and willingness to accept vaccines. And there's a lot of mistrust around vaccines for sometimes very good reasons in some communities. Yeah, I don't know what to say about that beyond the fact that every time that this comes up for me with a patient, it does lead to a long conversation, not that long, but a longer conversation than I might have otherwise expected to have with that person to provide some education around what this is. The key point, of course, being that this is time-limited protection. Perhaps it's a useful way to segue into conversations around the importance of adherence. But of course, injections do facilitate adherence, and the clinical trials show that.
Thank you. And before we finish, Greg posted the material, the PDF material or the article in the journal. So CMAJ guidelines. So you have the two links, the link direct to the article or to the PDF site. Also, there's the two URL that Daryl taught, the KT material, the French and the English. Also, Anna is already announcing the next webinar that will be given by a colleague of you, Vanessa Allen in Toronto. So we try to keep the monthly webinar. And at the end, also there's a call. IUSCI Canada is important. I think that's where we get the most exchange, the networking we have between Canadian experts. Frequently, we're outnumbered by experts of other countries, and I think IUSCI Canada membership help us have this networking and share the discoveries that are made. So you have the different price of the membership. It gives you also the benefits of networking, specialized content with the webinars, volunteer opportunities, scholarship opportunities for early career membership. And also you get your membership in IUSCI World. And what a luck, when you have your membership with IUSCI World, you get access to the most of the recording that we were able to do last summer in Montreal, July 2025. We had the STI and HIV 2025 World Congress, and we have fantastic recording from various people like Henry DeVries, who did the opening lecture, Shake the Cage. Henry, he did, I think it's a good hour to listen to something really refreshing, how to resist and how to reassess what's happening with the cuts that we're seeing around the world. And also the closing lecture that was done by Jeannie Marazzo. Jeannie was famous for having some little difficulties in United States. Now, I think she has IDSA, but it's a closing lecture that is also worth seeing. A lot of material that have been presented there and free to access if you are a member. So we're at the closing of this meeting. We thank Dr. Daryl Tan for giving us a very thorough walk, the guideline, the PrEP and the PEP guidelines. So thank you very much, Daryl, for your time. Thank you, Greg, for the logistic, and Anna for the publicity. So I hope to see you all in a month for Vanessa Allen lecture. Bye for now.
Thank you.